Okay, welcome back. So we had a chance to take a look at and review some of the, pathophysiology as well as the pulp biology and physiology that is the foundation of some of the diagnostic terms that we're using here, and some of the symptoms and some of the tests that we're going to later on try to duplicate during our during our patient interview as well as the clinical tests. But before we do that, I just want to kind of share with you not so much brand new. In 2009, the American Center of Endodontists had a consensus opinion and a meeting where they kind of came up with a new terminology to describe the clinical diagnostic terminology that is used to describe pulpal and periapical diseases in our patients. And as I mentioned before, it's very important that we kind of assign a proper pulpal and apical diagnosis to any patient in which we're going to be doing a root canal therapy on. That is really a legal responsibility. And in order to do that, we need to also use the proper terminology. Some of the older terminology that has been used is no longer valid. Sorry, we're going to have to learn brand new and learn all this stuff from scratch. But I'm hoping that right now, and maybe even later on during the differential diagnosis part of the course, which is the step after the last, we can go over some of these terms, and hopefully by then you will be comfortable using them. First and foremost, let's talk about the pulpal diagnosis. Obviously, we start from a normal state in which you have all of your, the tissues are there, you don't have any symptoms. A normal pulp would respond to the cold without any kind of lingering reaction. So the A delta fibers are intact, which is your rascal plexus is intact. You have your little processes, blast processes going into the dental tubules, and they're supported by the nerve fibers. So signals go through, no problems. Then we have a situation in which we have injury to the pulp, let's say in form of a small carious lesion. Now, a carious lesion can cause pulpitis, even though it may be just barely into the dentin. And the reason for that is because of the dental tubules. As we explained, the dental tubules are conducting the permeable, and despite the fact that there is a outward flow, that helps, clearly delay the process of infection. And that's probably why when you even have exposed dentin in some parts of the tooth, you don't end up getting necessarily an infection. And also the same reason why in some cases you may have no sign of decay or problem. For example, in some canines where you have exposed dentin, and you will end up having a pulpal necrosis for apparently no reason at all. That is probably because of the fact that you will end up getting bacterial contamination through the dental tubules because there's no cementum covering the dentin at that point. But let's get back to reversible pulpitis here. Conduction of either bacteria or even bacterial byproducts through the dental tubules can create a local inflammatory response inside the pulp. Now, we call that clinically reversible pulpitis if you do your testing and there is no lingering response to the cold test that you do, which lasts beyond, 10 seconds, 5 to 10 seconds. If it lasts longer than that, then you might be, talking about an irreversible pulpitis. A reversible pulpitis is a situation in which if you address the source, you remove the decay and place a well-sealed restoration, then you will have, recovery of the pulp. The pulp will recover well and it will have no problems. Irreversible pulpitis, on the other hand, is a situation in which the decay, it could even be shallow. It would appear shallow, but adequate amount of bacteria or bacterial byproducts have reached through the dental tubules or directly inside the pulp where the amount of infection or inflammation overwhelms the pulp. As I mentioned, because pulp is encased, it doesn't have either collateral circulation or any ability to compensate for the inflammation, and that overwhelms the pulp, and that can't recover from it. As we mentioned earlier on also, that the difference between the reversible and irreversible pulpitis at a clinical level is designated by whether the tooth is having spontaneous pain or is having lingering pain to thermal stimulus, and that could be for 10 seconds or more. Of course, everybody has their own thing. Some people say more than 10 seconds, some people say more than 30 seconds, some people say more than 15 seconds. No one test is ever diagnostic enough on its own. And I hope that's one of the things that we can basically get across during this presentation, that you need at the very least 2 specific signs and symptoms to corroborate in order to have a diagnosis. So that's the difference between reversible and irreversible pulpitis. Now, in the new terminology, irreversible pulpitis comes in 2 flavors. you can have, so you got your irreversible pulpitis, and that could be either symptomatic or asymptomatic. Now, symptomatic irreversible pulpitis is clearly the notorious tooth with the pain. Patient comes in, I haven't slept for the past 2 nights. I'm having deep throbbing pain, wakes me up in the middle of the night. Spontaneous, you do your testing, you put a cold on the tooth. The patient is basically hitting the ceiling. It's just that sensitive to the cold, and it lingers afterwards. That is your symptomatic irreversible pulpitis. Very important to distinguish that. Now, you may say, well, what is asymptomatic irreversible pulpitis? That's almost counterintuitive. And what that is basically, it gives people a clinical diagnostic for when you have a situation in which you have tremendous amount of decay on the tooth. The patient has no symptoms, but you do need to do the root canal almost pre-prosthetically or prophylactically, because there is adequate amount of infection there that by the time you remove the infection, you're going to have a pulpal exposure. So those cases get assigned in asymptomatic irreversible pulpitis for the pulpal diagnosis. And that is just a practical clinical approach to the problem. Now, as we mentioned, once the pulp is overwhelmed with the amount of infection that is in there, you can end up getting a pulpal necrosis where the pulp basically either liquidates and necrotizes through liquefaction necrosis or coagulation necrosis in the cases of a trauma or something like that, and then the pulp is dying. When the pulp dies, you basically will not have any response to your A delta fibers because those are the ones that die first. The C fibers will die last, so cold goes to hot, and then later on, even the heat doesn't respond. That's in the cases of necrosis. Pulpal necrosis clearly always requires root canal therapy, and the idea here is the basis of foundation of root canal therapy, which is to remove all the microbes that have caused the necrosis. As I mentioned before, you can have asymptomatic necrosis also, which is not a term that is defined, but those are pulpless teeth that have become pulpless as a result of trauma. Now, so that's necrosis there, and then previously treated. Previously treated is a new kind of a terminology. Well, not a new terminology. It is previously treated has been around for the longest time. It's just a tooth that has had a previous root canal. So now you have to have a pulpal diagnosis even on a tooth that has had a previous root canal. So you just call that previously treated pulpally. But then there's a new one, which is previously initiated therapy, and that is a case in which previously initiated, and that is a case in which somebody does a pulpotomy and then sends the patient to you for completion. You need to still have a pulpal and a periapical diagnosis, and then you would use that as a previously initiated root canal for your pulpal diagnosis. Now, let's move on to the apical area. We know, so we've had this, normal, reversible, irreversible, symptomatic, asymptomatic, necrosis, previously treated and previously initiated for pulpal. And now let's get into the apical diagnosis. The apical diagnosis, obviously, as usual, starts with the normal state of a tooth was one that doesn't really respond in a sensitive way or in a painful way to percussion because the tissues there are not inflamed. But as soon as you have inflammation that reaches from a necrotized pulp or an irreversibly inflamed pulp where the infection has actually reached or inflammation has reached the apex, you will end up getting apical periodontitis. Apical periodontitis, so we got normal, you got apical periodontitis. And that also comes in 2 different flavors. We got your symptomatic one and your asymptomatic one. Your symptomatic apical periodontitis is also the notorious tooth with with a lot of pain. Oftentimes, it could be associated. Symptomatic apical periodontitis would be associated with a symptomatic irreversible pulpitis, and the combination of the two are the most painful patients that we're going to be dealing with. These patients are also very difficult to anesthetize because at that point, all of the whole complex here is in hyperalgesia. There is just a tremendous amount of sensory feedback that's going up to the brain. Blocking the nerve at that point is not so easy. So that's symptomatic pulpitis. It's very exquisitely sensitive to percussion. And, that doesn't say anything about the pulpal status because you could have irreversible pulpitis in which a tooth would be sensitive to hot and cold, but also have symptomatic apical periodontitis. Asymptomatic apical periodontitis is a situation in which you basically have a periapical lesion in which you've had already at some point, some apical periodontitis that has resulted into bone loss. So you see patients all the time that have periapical lesions. They're not even aware that they're having a problem there. And that is really the definition of apical periodontitis that is asymptomatic. These patients will not obviously have any response to the pulp vitality testing, because they should have a non-vital pulp to begin with. And in cases where you see a lesion at the end of the root, where you do your pulp testing and it is a vital response and a normal response, then you clearly know that that is not your asymptomatic irreversible pulpitis, and it would be a non-odontogenic source, whether it be a source or something else we can discuss later. So once you've done your apical periodontitis, the next step is apical abscess. Apical abscess. So apical abscess is basically a situation in which you have also two flavors, either acute or chronic. The acute apical abscess is the case of a patient who comes in to see you, has swelling and is in pain. So acute shows the nature of a rapid onset type of an infection. You have fluctuant swelling in the area. You have a patient in pain, sensitive to percussion, should pretty much always be associated with negative to any pulp testing, because the pulp should be necrotic at that point. And that basically that's also a very painful situation. It could lead into cellulitis. The abscess could follow fascial spaces and so on. Or it could drain, and that would end up being then asymptomatic, or rather, so that was acute, and then you can have chronic, and that will be your chronic apical abscess. A chronic apical abscess is a typical tooth with a sinus tract. You have had an abscess, but now you have drainage. As a result of that drainage, that sinus tract is a path for the abscess to drain into the oral cavity, so it almost acts like a pressure valve. It releases the pressure that would otherwise be causing pain, which is why patients that have sinus tracts don't have pain, because the pressure of the abscess is actually being drained. They oftentimes describe a metallic, salty taste in the mouth, or a foul taste, and that is basically the abscess draining into the oral cavity. They would have always a necrotic pulp, and they would have no response to pulp vitality testing, and their apical diagnosis would be a chronic apical abscess in the case of a sinus tract. And then lastly, this is another one that they have added, which is your condensing osteitis. Condensing osteitis, we're not going to get into that much. It's basically just a bone, it's a clinical diagnosis of radial opacity at the apex, which is a bone reaction to inflammation that could be happening inside the tooth. And condensing osteitis could be associated with even a vital pulp, or a pulp that is irreversibly inflamed, or by a vital pulp, I don't mean a normal pulp, but a pulp that is inflamed. And also it could even be associated with an asymptomatic apical periodontitis, where there is a lesion and then there is a bone reaction, which is your condensing osteitis outside of it. So these are some of the important text and terminology that you need to know in order to have your pulpal and periapical diagnosis. What I want you guys to take home with you is first memorize these names, because you need to know them legally in order to assign a pulpal and apical diagnosis to a patient, and also know that these clinical diagnostic terms have biological basis, which we explained in the previous video, which I hope you watched, and if you haven't, please go back and watch it.